into the inferior thyroid artery, the transverse cervical artery, and the suprascapular artery. Remember that the vertebral artery will travel straight upwards towards the cranial cavity, and on its way up, it'll start entering the transverse foramina of the cervical vertebrae at cervical vertebra C6. Branching off of the second part of the subclavian artery, and remember the second part is actually going to be posterior to the anterior scalene muscle, so why don't we have a look behind here, and you can see the artery back there. This would actually be your costocervical trunk. The costocervical trunk usually divides into two more arteries, which would be the deep cervical artery and the supreme intercostal artery. And then we have the third part of the subclavian artery, which only has one branch, and the third part would be in that case lateral to the border of the anterior scalene. Well, in this anatomical model that we don't really have the dorsal scapular artery coming off of here, but in many cases you would have the dorsal scapular artery arising from the third part of the subclavian artery. However, in this case, we have the dorsal scapular artery coming off as a branch of the transverse cervical artery. And this pattern where the dorsal scapular arises as a branch of the transverse cervical is present in approximately 30% of all anatomical donors you will encounter. So next, let's have a look at some of the veins that we can find in the neck. We can see right here highlighted is our so-called external jugular vein. Medial to that is going to be the internal jugular vein. Who would have guessed? Same thing on the left side here. And so the EJV, or external jugular vein, is important for draining blood that is primarily received from the scalp and the face. Okay, so the EJV will then terminate in the root of the neck by joining here the subclavian vein. Okay, there's also sometimes an additional vein called the anterior jugular vein that's variable. It would also terminate in the root of the neck. If we look a little bit further down here, I always find that it's quite interesting to facilitate our view. I've actually made parts of the sternum and some of the cartilaginous parts and connective tissue of the sternoclavicular joints invisible. And now we can see up here is the superior vena cava. On the other side, all the way down here. Also entering the right atrium is going to be the inferior vena cava if we go all the way through here. And so the superior vena cava, often abbreviated as SVC, is made up of the union of the right and left brachiocephalic veins. Remember, in anatomy, as I often say, the name is the game, and so in that case it is going to be a vein, brachiocephalic. That means it is described best because it drains blood from the brachium, so the arm, and the cephalon, the head. All right, good. So that is actually indeed true. It drains blood from the arm and or actually, I should say the upper limb and from the head region. And if you look at the two brachiocephalic veins, you can see that the left one is actually much, much longer because it actually has to arch all the way over, no pun intended, the arch of the aorta, whereas the right brachiocephalic vein has the ability to be very, very short because it just immediately, well, nearly immediately then splits into the subclavian vein and internal jugular vein. This you can then split into the internal jugular vein and the subclavian vein. So if I add in the lymphatics here, you can see it becomes instantly very, very busy. But what I'd like to point out are two important structures here which we can find joining the right and the left venous angles. On the right side, this is actually called the right lymphatic duct. And on the left side, it is actually called the thoracic duct, right? So these are the major lymphatic routes by which lymph is returned to the venous system, although important to note that the thoracic duct actually drains the vast majority of lymph of the entire body, whereas the right lymphatic duct only drains the right upper quadrant. That actually includes all of the right upper limb. All right, so your right lymphatic duct will return the lymph into the right venous angle, which is actually the angle between your IJV and subclavian vein. And the thoracic duct enters at the angle between the subclavian vein and the IJV on the left side, respectively. So let me go ahead and hide those lymphatics again. Good. Okay, so now we can talk about the nerves a little bit. There are going to be 3 pairs of nerves in the root of the neck. For this, let me just highlight all the nerves again. Good. Okay, so pretty busy. We know there's going to be a lot of nerves to find in the neck. Importantly, if we think of the root, as I just said, we have 3 pairs. We have first the pairs of the vagus nerves, right? The vagus nerves run pretty much medially down the root of the neck. Here's actually the left vagus nerve. I can isolate that for us just for a second here. Here's the left vagus nerve. Okay, you see it actually exits through this hole in the skull. If you've already seen the corresponding video, you will know that it'll exit out of the jugular foramen, and then it'll course all the way down the neck, and it'll loop around the arch of the aorta to form, or to give off the recurrent laryngeal nerve on the left side, whereas on the right side, the vagus nerve, that should be this one here. Let me see if I can click on that. Yep, on the right side, the vagus nerve, well, there's no arch of the aorta for it to loop around, so on the right side, the vagus nerve will continue inferiorly, but the recurrent laryngeal nerve on the right side will be given off around the subclavian artery. So there's a loop on both sides, although on the right side, the loop is much, much shorter, and on the left side, the vagus nerve is much longer until it continues further down. In addition to that, you also have the phrenic nerves on the right and on the left side. The phrenic nerves are going to be just a tad further lateral to the vagus nerve, and this would be the phrenic nerve on the right side, and the phrenic nerve will actually be running on the anterior surface of the anterior scalene, goes all the way down, It goes down to the diaphragm here, and it comes originally from the levels of C3, C4, C5, because C3, 4, 5 keeps the diaphragm alive. And on the left side, here should be a phrenic nerve as well. Here's the left phrenic nerve, also traveling inferiorly in very close proximity to the pericardium of the heart. That'll be in both cases, and then it goes to the diaphragm. And last but not least, we also have the sympathetic trunks. In the neck region, although you don't have a sympathetic ganglion associated with every vertebral level, you do have a couple of ganglia that have fused together. Usually you have 3 ganglia, an inferior, a middle, and a superior cervical ganglion. Here's the superior cervical ganglion. If I isolate it, you can see where it sits, pretty close to the inferior aspect of the skull. But if you're looking from the root of the neck and you kind of work your way medial to the carotid sheath and then all the way upwards, you can see here is your superior cervical ganglion. In my mind, it always looks like you have maybe like 2 or 3 beans that were rowed end to end, and then someone stepped on them and squished them a little bit. That's kind of what it looks like. Remember that at this level, you will not find any preganglionic sympathetic fibers. You'll only find the preganglionic sympathetic fibers between T1 and L2, because that is where within the spinal cord you have the intermediolateral cell column where these preganglionic neurons for the sympathetic system sit, only between T1 and L2. However, fibers that need to go to the head and neck region will enter the sympathetic trunks or chains and then ascend if they have to go to the head region, and then they will synapse on an appropriate ganglion depending on the level that they have to go to. The highest they can go to is of course the superior cervical ganglion. Then they will exit via gray rami communicans, or some call them cephalic arterial rami, to then get distributed to their target regions within the head region here. So now let's have a look at the thyroid gland, which is the largest endocrine gland in the neck. Very important because we need to make thyroid hormones, but even more important, we need to make parathyroid hormones from the parathyroid glands that are embedded usually on the posterior aspect of the thyroid gland itself. Interestingly enough, the thyroid gland does not develop in the neck. That is where it rests in the end, though. It usually develops actually as a median epithelial outgrowth or downgrowth from the floor of the pharynx in the region where the tongue develops. On the tongue, on the back of the tongue, you have a little foramen left over called the foramen cecum, and it was connected via a long duct called the thyroglossal duct all the way down to the thyroid here. So in some donors, you'll have an extra lobe that comes up here. It's kind of in the midline, and it's called a pyramidal lobe. That is actually quite frequent, and it's not associated with any kind of pathology. And you can see the final resting place of the thyroid gland is then here in the neck. Sometimes a little bit of the thyroglossal duct stays left over, and there can be a cyst that develops that would be called a thyroglossal duct cyst. These aren't really very worrisome, and they can be removed if they are bothersome or aesthetically unpleasing. The arterial supply of the thyroid gland is via primarily the superior and inferior thyroid arteries. You can see here's your superior thyroid artery coming off of the ECA or external carotid artery, and the inferior thyroid artery down here is coming from the thyrocervical trunk. In some cases, I think about 10% of cases, there's an additional artery that goes to the middle aspect or the median aspect of the thyroid gland about here, where the pointer is now pointing. That would be called the thyroid ima artery or thyroidea ima artery. That's something that a surgeon has to be aware of when they're doing a thyroidectomy, because if you cut this little vessel, then of course it'll bleed severely, so you need to know that in some of your patients you're going to have to expect that to be there. So here we're looking at the isolated thyroid gland. We're looking at the posterior aspect. Here you can see your 4 parathyroid glands. These here are truly endocrine glands that are essential to life because they will secrete your parahormone or parathyroid hormone that stimulates the mobilization of calcium from the bones to maintain a normal blood calcium level. So if these are overactive, it can lead to demineralization of your bones. So that means that people who suffer from this might actually fracture their ribs by even simple things like turning over in bed. And of course, they might also be more predisposed to getting renal calculi, so kidney stones. If they are underactive, it can lead to tetany, which are these very severe muscle spasms. And since, of course, the diaphragm is a muscle, if that is affected, it leads to death.